Thank you guys so much for having me. I'm very excited to be here. I just want to let you guys know my goal is actually to, I'm going to be talking at you for a while, which is the nature of a grand rounds. But, and I do have a lot of information to go through, but my hope is to really save, my goal is to have, to save at least 15 minutes for questions. So definitely, as I'm talking, please think about your questions, send them in, and I'm very happy to have a robust discussion towards the end. Also, just to reiterate, I have sent out some handouts for you guys that have lots more information. If you want to delve into this at a deeper level, or if you need support resources, there's a lot of stuff that I have provided that I hope that you can utilize in the future. And you're also always welcome to contact me if you have further questions about any of this. Hopefully you will hear from my voice and from the information I'm presenting that I'm very passionate about this stuff. It is the highlight of what I do. So I'm very excited to share this with you. That being said, I will share my screen, and I'm oftentimes technologically challenged, but I hoping this will work out. Let's see, share your screen. Here we go. Okay, let's see. Can you guys see this okay?
Yes, ma'am.
Wonderful. Okay, here we go. So obviously I'm talking to you about medication for opiate use disorder, MOUD. So it used to be called medication assisted treatment, but we're using different terminology these days that is a little bit more friendly. So when I say MOUD, that's what we're talking about. Okay, the learning objectives are, we are going to describe the current state of the opioid epidemic, explain the value of medication for the treatment of opiate use disorder, explain the role that primary care physicians can play in combating this epidemic, and describe different models of providing buprenorphine, aka Suboxone, in the primary care setting. Here we go. So I'm going to start with a video to get your juices warmed up into a real clinical case. So give me a second while I share I get the video up for you guys. Oops. Let's see.
Captain for lacrosse, would have been, junior year football, lacrosse. Love contact sports, hockey, football, lacrosse, junior year varsity, I was captain for lacrosse, would have been senior year as well. Football was captain, varsity, senior year, getting into hockey. And I went to hit a kid on the other side of the team. We were playing hang 'em mass, and I ended up breaking my wrist. And I had pins in my arm and extensive nerve damage as well. So the solution.
A parent's worst fear is to have their children suffer. It's impossible to imagine the suffering of the families devastated by the earthquake.
Solution to the pain from the doctor, of course, was prescription pain medication. And, at the time I wasn't even aware of, what that was. For me, I'm getting it from a doctor. It must be okay. I remember the first time I took the pain medication, something just, a light just went on. Something happened to me where as soon as I started taking them, I had cravings for them. And for me, pain medication was easier to get growing up than alcohol was for a lot of kids. So I started taking this prescription pain medication, and then all of a sudden, I became very dependent upon it as well. When you hear the word heroin, it terrifies most people, most families, most kids. It has that name branding effect. When you hear the word Percocet or blues or 30s, we call them, oxycodone, it doesn't have that name branding effect. But the fact of the matter is it was, synthetic heroin in a pill. We're taking heroin in a capsule. At this point, it wasn't even the enjoyment of getting high. It was just, I was so deathly scared of being sick every single day that I just had to take something to function normally. You know, like when I grew up, I had dreams, I had goals like any other kid. I didn't grow up when they asked you what you want to be when you grow up and say, I want to be a drug addict. You know, I wanted to be a professional athlete. I wanted to be a doctor. I wanted to be an attorney. Anybody that cared about me, anybody that loved me, I just started pushing them away because I felt like, when my parents, they knew what was going on with me. They didn't understand, but they knew something was wrong. As you're in the game long enough, you start seeing things and doing things that you never thought you would ever do. Things that I was never raised to do, things that I choose not to talk about today. But the fact of the matter is you also surround yourself with other drugs. And, eventually, I was with heroin, I seen heroin so much, so consistently that it became a no-brainer one night when I was sick to do it. It was okay. I'd rather not be, completely sick, deathly ill. Let me take this to make myself feel better. Detox just became a revolving door. They call it a spin wash, in for a few days, clean yourself up, get out and go right back in a week later. And it just became a vicious cycle. Everybody that I knew was getting high or drinking every time I was trying to get sober. I had to separate myself and find young kids, in recovery that, were having fun and enjoying themselves because I didn't know how to have fun without putting a drink or drug in my body. I got myself on a plane and went to a treatment facility. And, the first couple of weeks I was in there, I was completely negative, completely hopeless. I've done this before. It's never worked before. It's not going to work this time. See, what I learned is there's no cure for my problem. All of a sudden, now that I have my life together, I can't stop taking care of myself because I will be right back where I started. I'll lose everything again.
All right. Okay, let me go back. Okay, so I think that's a really touching story, and I think we can probably all think of somebody we know who's been affected by the opioid epidemic. And the reality is it's so widespread and it touches everybody. There's no socioeconomic demographic that is not affected by the opioid epidemic. So I think it's important to remember these stories and think about how we can be part of the solution. So as I'm sure you guys know, that we are in an opioid epidemic, and it actually has been getting worse through the pandemic. With social isolation, people not having access to care, the numbers of opioid-related deaths has continued to increase. In your state, in Arkansas, in 2020, there were 546 opioid overdose deaths. Interestingly, what is causing all this, the number one cause of opioid overdose deaths is fentanyl, synthetic opioids. So fentanyl, unfortunately, is in everything people are taking. Even people who are smoking pot, fentanyl is laced in that. It can be in Percocets on the street. It's causing a lot of overdose deaths because fentanyl is 50 to 100 times as strong as heroin. So that's one of the reasons our epidemic has gotten so much worse. We've actually had 3 waves of the opioid epidemic. It started off with prescription opioids. And as doctors became more aware of what was going on and became more judicious in their prescribing, we started prescribing less and patients went to the street and they started getting heroin. So the second wave was due to heroin. And recently, over the past decade, it's really now been synthetic opioids, fentanyl, which is really driving the epidemic. So despite all of this, the gravity of the situation, we actually have evidence-based approach for how we can help patients struggling with opiate use disorder. So any type of substance use disorder, we usually think of in a chronic disease model where we couple medication treatment with behavioral change that people can engage in. I will say that we have obviously a lot of addictions out there, cannabis and alcohol use disorder and stimulants, but of all the substance use disorders, opiate use disorder has the most evidence for medications. Medications are highly, highly, highly efficacious for this addiction. So this is one of my favorite graphs because it shows the benefits of medications for opioid use disorder like buprenorphine or Suboxone, methadone, and naltrexone, also known as Vivitrol. So those three medications, highly effective. So if you consider the general population has a mortality rate of about 1, if they are not, if a patient struggles with opiate use disorder and they are not given treatment with medications, their mortality rate goes up 6-fold. However, if we start one of these medications on that patient, their mortality rate falls over 3-fold, between 1 and 2. So huge mortality benefit. There's very few medications I can prescribe in the primary care setting that offer such mortality benefit. Every time I write a prescription for Suboxone, I literally feel like I'm saving a life. Unfortunately, only 2 in 5 patients with opiate use disorder receive these evidence-based treatments. There's a lot of reasons why, and a lot of it relates to access to care, providers not feeling like they know how to prescribe these medications, or feeling, maybe I don't have an appropriate support, or, oh goodness, what if I can't address this patient, all of their other needs and their psych needs, or maybe this is a complex patient population. My hope today is to make this feel very doable and recognize how important it is to be prescribing medication that offers such mortality benefit. I will say personally, when I started doing this work about 10 years ago, I really didn't know much about what I was doing. When I went through residency, I got no training in any of this. I barely even knew what Suboxone was. And then I entered a fellowship and I saw there was a need, and I talked to people and I developed mentors and I figured it out. And I think one of the things that I have learned, and that a lot of people who do this work, what I've heard from them too, is that, the alternative to not providing this is people using on the street and dying. So whatever fears we may have about prescribing this medication or prescribing medications and helping support this population, the alternative is clearly not a wonderful or great option. So delving into this and feeling like you can make a difference, and then you learn along the way, that's what I found has been kind of the trajectory of a lot of people doing this work. However, I am here to help support and provide evidence and guidance of how to do this. So explained another way, if somebody were to go into a detox and they're using opioids, they get detoxed off their opioids, and then they're not continued on maintenance medication like buprenorphine, methadone, or naltrexone, guess what their mortality rate is in the next, or their relapse rate within the next 3 months. Relapse rate off medications in the next 3 months is 90%. However, if you start people on these medications and continue it at a year out, there's about a 40 to 60% maintenance rate, meaning those people are still in recovery. So these medications work and they help keep people in recovery. So we are going to, I want you guys to put on your pharmacology thinking caps, because we're going to delve into the different medications and how they work. I think it's important to understand exactly what they're doing, because it helps you understand how to use the medications. So our 3 medications for opiate use disorder, you guys probably know methadone, buprenorphine, and naltrexone. So methadone is a full opioid agonist. This means that when it binds to the opioid receptor in the brain, it fully stimulates it, right? So the whole idea is that you're creating a blanket. All those receptors are saturated. If all the receptors are saturated, your brain says, I don't have any cravings. I don't need to use heroin or fentanyl. I feel satisfied. So that's what it's doing. However, the higher and higher you go, the more euphoric somebody can feel. So it has to be highly regulated. Patients who are getting methadone for opiate use disorder must go to an OTP, a methadone clinic, where they get daily dispensed methadone. It usually comes in a liquid form and they take it every day. So it's observed and it's highly regulated. The idea is that somebody should feel normal on methadone. Sometimes people associate methadone with people nodding off and not really are being too sedated. If methadone is titrated up appropriately, it shouldn't make people feel that way. The idea is to titrate it up enough So people don't have cravings, they don't have opioid withdrawal, but not too high where they feel sedated. So it is a great option for helping patients feel normal, stay in recovery. As you can probably imagine, though, going to a daily methadone clinic is associated with a lot of stigma for some patients, right? You have to go to a place, when you walk in there, everybody knows that you're going in there for that. There's also neighborhoods who don't want methadone clinics in their neighborhood. So there is a lot of stigma associated with that. And it also requires people to go every single day. Now, when people are doing well over a period of months to years, they can gain what's called take homes, where they don't have to go every day, but that takes a lot of time to acquire those privileges. At the other end of the spectrum is naltrexone. The injectable form of this is Vivitrol, which you guys might have heard of. So it is a complete opioid antagonist. Essentially, what's happening is it binds to those opioid receptors and it blocks everything else. So if somebody is to use fentanyl, the fentanyl just doesn't work. So it's protecting those receptors so the patient cannot overdose and die. It also prevents cravings. The mechanism of that, we're not exactly sure, but people who are on naltrexone, again, say they feel normal. They don't have cravings, and they know that if they were to use it, the fentanyl wouldn't work. This can be prescribed in an outpatient setting, or it can be injected in an outpatient setting. Again, it's a non-opioid, so there's no regulations behind it. Finally, there is buprenorphine, which we're going to focus on today because we can prescribe this in primary care. So why is this such an effective and wonderful medication? Is that it is a partial opioid agonist, meaning it binds to the opioid receptor and it partially stimulates it enough so that that patient says, I don't have cravings, I don't have withdrawals, I just feel normal. And that's what people taking buprenorphine, Suboxone should feel. They should feel normal. I can wake up every day. I don't have cravings. I don't have to feel like I have to go meet my drug dealer. I can go to work. I can take care of my kids. I can do the things that I want to do. So it makes people feel normal. It also has a ceiling effect, meaning once you go beyond a certain point, taking more just doesn't do anything. People are not going to get euphoric from it. They should not feel high. And if they take too much, it's not going to cause respiratory depression like methadone would. So it's considered a very safe medication, and it's considered a very effective medication. And on top of that, we can prescribe it in primary care. And walking into your doctor's office, your primary care doctor's office, nobody knows you're going there to get buprenorphine, right? So there's a lot less stigma associated with it. And it doesn't require daily prescriptions. When I write a prescription for Suboxone, I'm usually writing anywhere from a week to a month. So patients can come in less frequently and, still go to work, still live their life and get their medication. The other thing about buprenorphine is while it partially stimulates the receptor, it binds to that receptor very, very, very strongly. I like to think of buprenorphine as like a magnet. It sticks on there and anything that comes its way, it's going to get rid of. So if you can imagine, if buprenorphine is on the receptor, that opioid receptor, and somebody uses fentanyl, nope, that fentanyl is not going to win out. Buprenorphine says, sorry, fentanyl, I'm on here. You can't come in. So people taking it will not be able to get high from using fentanyl. At the same time, if somebody has fentanyl in their system and that's fully stimulating those opioid receptors, and then they take Suboxone, they go from fully stimulated to partially stimulated because the buprenorphine just kicks it out immediately, and that can cause what's called precipitated withdrawal. So the lesson is that if somebody is on fentanyl, taking fentanyl off the street, and you start them on Suboxone, you need to let the fentanyl leave the opioid receptors before you start the Suboxone so you don't cause worse withdrawal. But just to kind of recap all of this, buprenorphine, very safe, ceiling effect, highly efficacious. The other thing you guys might have heard is recently we have had to, since buprenorphine was created in 2000, over the past 20 years, people have had to get extra They had to get a waiver to be able to prescribe buprenorphine, meaning they had to take hours of classes and do all this work. And it's a little ridiculous if you think about it, when we can prescribe Percocet and oxycodone all day long, but we have to get an extra license to be able to prescribe buprenorphine. Well, as of a few months ago, that has gone away. Anybody with a DEA license to prescribe controlled substances can now prescribe buprenorphine. And when we consider its safety profile, it makes total sense. This should be bread and butter work of what we're able to do in primary care and to help save lives. Okay, so this is a slightly complicated chart, but it says the same thing that we just went through. So very briefly, just to summarize, buprenorphine, partial opioid agonist. To let you know, the daily dose is usually 16 to 24 milligrams a day. It's taken sublingually under the tongue. There's also a version that's available as a monthly injection for people who don't want to take a medicine every day and just want a month long, knowing that they have buprenorphine in their system and that they have a month of sobriety. If they tried to use, it would not work. Buprenorphine has a ceiling effect, and it is now available for anybody with a DE license to prescribe. Methadone, full agonist, again, usually titrated up to between 80 and 120 milligrams a day. It comes in a liquid form. There is risk for respiratory depression if there's too much in the system. You have to worry about QT, prolongation, and it has many medication interactions, can only be given at a licensed OTP. Now, just to be clear, if you're prescribing methadone for pain, yes, we can do that in the primary care setting, but methadone for opioid use disorder has to be at a licensed methadone clinic. And then again, naltrexone. So it's an antagonist. There's a PO form and also a monthly injection form. Starting naltrexone is a little bit trickier. You have to wait till opiates are out of the system, about 7 to 10 days. And for patients who are using fentanyl every day and multiple times a day, that can be challenging. So it's a little bit harder to start naltrexone, but once people start it, they tend to do well. No restrictions on prescribing. So one of the questions I often get, and a lot of people are asking, is, well, how do I know who's better for Suboxone? Who's better for methadone? Who's better for naltrexone? There's a lot of guidelines out there. There's a lot of algorithms that have been put together. But the bottom line is there is no one perfect solution. And usually the best rule of thumb is, what does the patient want to do? Now, most patients know more about this stuff than we do. The number of times I've had to have a conversation with, well, do you know the difference between Suboxone and methadone and Vivitrol? Most patients know the difference. Many of them have tried Suboxone on the street. They know patients who've been in methadone programs or they've done it themselves. They usually know what they want. So 9 times out of 10, we ask people what they want. And if people are coming to us for Suboxone, we usually go for it. If they start a program on Suboxone, they're not doing well with it, then we can have a conversation down the road of, hey, you're still, you're not doing well in your recovery. Maybe we might think of other options. But again, 9 times out of 10, the patients tell you what they want. I remember I actually had a conversation with a patient once who was in a methadone clinic. And I just remember asking him, you have to go there every day. Why did you choose to do methadone when you could do something like Suboxone? And he said, well, for me, I do really well with routine. I wake up every morning. I like to go to my Dunkin' Donuts, then I go to my methadone clinic, and then I go to work, and it keeps me on track. So again, methadone has a lot of accountability associated with it, showing up every day, getting a medication. Suboxone is helpful for patients who don't necessarily want to go to a clinic every day and don't want, or maybe don't need that level of accountability. But again, it goes back to, what does the patient want? And that's usually how we start working with them. Okay. Quick review of how to take Suboxone. So again, buprenorphine is sublingual, and I always try to make sure patients know how to take it, because if they don't take it correctly, it's not going to work. So basically, rule of 15. 15 minutes before you take it, no food, no drinking, no smoking. And you put it under the tongue, let it dissolve for 15 minutes. 15 minutes after taking it, no food, no drinking, no smoking. And then just to let you know, these medications are approved for some for the pediatric population. So Suboxone can start at age 16, methadone start at age 18, or you can start earlier if the patient has 2 prior overdoses and with parental consent. And Vivitrol is approved for 18 and over. In terms of pregnancy, just to let you know, the ACOG definitely recommends patients be on medication for opioid use disorder during pregnancy. The reality is if somebody is not, the relapse rates are super, super, super high, up to 90%. So the risk of relapsing during pregnancy is so high that it's recommended all patients go on some type of medication for opioid use disorder. So if they're on buprenorphine, they stay on buprenorphine. If they're on methadone, they should stay on methadone. If they're not on either of those, they should start one of them. It used to be thought that methadone was the gold standard in pregnancy, but there was a huge trial, it was called the Mother trial, that compared buprenorphine to methadone, and it basically showed that patients who are taking methadone, their babies end up having shorter hospital stays and require less morphine, and they require a shorter duration of treatment for neonatal opiate withdrawal syndrome. So essentially, both methadone and buprenorphine are considered gold standard and should be offered as first-line medications to pregnant patients. Okay, so we've talked a ton about medications. But there's other things we can do to help support patients. When I'm working with patients who struggle with opioid use disorder, yes, I prescribe, but we also talk about all the other things that we can do to help support them. So a lot of patients with opioid use disorder have other mental health comorbidities, depression, anxiety, PTSD. A lot of them have trauma histories. So if they are open to going into counseling or doing group therapy, that would be great. We often encourage them to go and get other support from other people who are in recovery. So offering them AA or NA groups. There's also something called Smart Recovery. For those of you who are not familiar with that, that is AA and NA tend to be a little bit more spirituality focused. That can be a turnoff for some patients. Some patients like it, but Smart Recovery is more cognitive behavioral therapy based. So it's less of the spiritual aspect. We often encourage patients to get sponsors, somebody they can call and check in with every day. And then there's recovery coaches. I work a lot with recovery coaches. These are people who have a history of addiction and have been in recovery for a while and dedicate their life and get paid to help support patients. And it's a great way for patients to connect with others who have a similar experience. And then encouraging other things that can be healthy to patients, getting them working and volunteering, doing exercise, yoga, meditation, martial arts, anything that helps them feel a sense of value and contributing and doing things to take care of themselves, helping them get jobs, get extra training. All that stuff is really supportive for recovery. Patients always tell me that if they have accountability and they have regular schedule in their life, those are things that are super important to help them stay on track. Life in the world of addiction is very chaotic. So having some structure to their day kind of helps them stay on track. Other options, I don't know if you've heard of halfway houses or sober houses, but these are living facilities where people who struggle with addiction can live and have a lot of accountability and support from each other. Okay, and then finally, I just want to mention levels of care. So we're talking mostly today about the outpatient setting, prescribing Suboxone in a primary care setting or prescribing methadone in a methadone clinic. But there are higher levels of care for people who need that. People can go to detox where they're taken, detoxed off their opioids and then sent to an inpatient program. Inpatient is great for people who really need a higher level of care. There's round the clock support for not only addiction, but mental health problems. They can be started on medications for mental health problems. They get lots of counseling, lots of support. People who are homeless or have other, instability in their life can get a nice, safe space for 2 to 3 months where their life is a lot less chaotic and they get a lot of support they need to set them up for success when they leave. There's partial hospitalization programs where people are going to hospital most most days of the week. And there's also IOP programs. So IOP lets people live in the community. They can sleep in their house, wherever they're living, and they come in maybe like 3 times a week to a half a day program and get some support. And that program usually lasts about a month. So it provides a little bit more intensive treatment than we can do an outpatient program. So there's step down version of this and there's step up. If people are not doing well in an outpatient setting, we can have a conversation. I think you need more support. You're clearly not doing well. Let's figure out what else we can offer you. Have you thought of an IOP program or going to an inpatient program? And then people who are at the other end can step down to outpatient as they are doing, they're progressing in their recovery. So one of the reasons I wanted to introduce this to you is for you to think about, too, it's nice to know what resources in your community exist. If you need to refer patients to IOP programs, if you need to refer them to inpatient settings, we actually rely a lot on our recovery coaches and other people with those specific areas of expertise to help navigate that for the patients. Okay. So I'm going to transition. I'm very aware of the time. The next section of this is talking about how can we do this. So I'm going to give you details, but I want to make sure to save time for questions. So I might fly through some of this, and there's tons of resources that we can provide, or I have provided for you if you want more of the details. One of the messages I do want to get across, though, is that I think we tend to see patients a lot in acute settings, right? We're in the hospital and they have had an overdose, or they have endocarditis or cellulitis from the complications of their drug use. And we see people really at rock bottom. And we see people when they're withdrawing, and they oftentimes are very uncomfortable, and they might come across very uncomfortable. So I think the inpatient setting can paint a picture of what addiction looks like. One of the reasons I love this work in the outpatient setting is we actually see what recovery looks like, right? Like I work with some patients, I do a lot of group-based treatment, and I've had patients in our group since we started about 10 years ago, seeing them go through life. And so one of my colleagues describes recovery as like a reverse country song, right? They get their dog back, they get their kid back, they get their truck back, all the things that are important. And we get to be part of patients' lives and see what this recovery journey looks like for them. Not that everybody doesn't, has a perfect journey, and there's people who struggle throughout, but doing recovery work in an outpatient setting, you get to know people at a different level, and you get to see them oftentimes accomplish very important things. As a primary care doctor, I see a wide variety of patients, and I generally love the work I do. However, there are sometimes I ask myself, what did I actually do today that made a difference? Yes, I can lower your blood pressure a little bit. Yes, I can lower your A1C a tad bit. Did that really make a difference in your life? And sometimes it might, but when I do recovery work, I do feel like it is very impactful, and we get to see those, we get to see people and their grow over time. So it's really one of the reasons I am very happy with my job. Okay, so how do we do this work? Again, I'm going to give you guys some general ideas. I'm going to give you some specifics of the way our healthcare system works and some other healthcare systems work. But my goal is also to give you themes of possibilities, because essentially every healthcare system is going to be different. The way you decide to treat opiate use disorder is going to depend on your resources, the policies you have in place, the people you have in place, your culture. So I'm going to throw out ideas for you to think about how could this work in your own healthcare system. So in our healthcare system, and in a lot of areas in this area and across the country, we use a nurse case manager, what we call OBOT nurse case manager. OBOT just means office-based opioid treatment, basically providing Suboxone in the outpatient setting. We use a nurse to kind of be the glue of the operation. So essentially, when somebody wants Suboxone, maybe they're coming off the street, maybe they're being referred internally from a primary care doctor, maybe they're coming from a higher level of care, that nurse grabs them and kind of does an intake with them, gets to know them, and then make sure they're appropriate for Suboxone in the outpatient clinic and gets them set up. Or if the patient wants methadone, the nurse can direct them there, or a higher level of care, the nurse can direct them there. So things start with our OBOT nurse. We do a lot of, so I work at Cambridge Health Alliance. We have 13 primary care sites, 2 hospitals, and we have every primary care site has lots of waiver buprenorphine, or lots of people providing Suboxone. Some people offer it individually, meaning they're seeing patients one-on-one, but we also do a lot of group-based treatment. So I'm going to touch briefly on what that means. But group-based treatment essentially is a way to combine prescribing of Suboxone with group support, meaning being in a group with other people who have opiate use disorder or have addiction. So there's different ways this has been implemented across our system. So I'll just share these with you briefly. I run shared medical appointments, which is basically everything happens in group. Patient gets their prescription and they do group therapy. And then they leave and they have primary care doctors outside of group that they see for other things. We reserve group just for addiction stuff. And then there are providers who will actually see patients one-on-one. Like I know a provider, she says Monday mornings and Thursday afternoons are my time where I'm going to try to see most of my patients with opiate use disorder. And then at the same time that she's seeing those patients, there is a group run by a therapist. So patients can go to the group and then pop out and see her individually. And she's working with them on following up on their addiction stuff, mental health stuff, any issues, other issues she can address. And then there's another version of this where there's providers who will sit in a group and run a group setting and prescribe buprenorphine. And then one of our providers who pull people out individually and see about 4 people after group individually every couple of visits. And just to, again, have a one-on-one with them, check in with them about their addiction, their mental health. He also tries to do preventive health maintenance stuff during that time. And he'll try to pull people out of group afterwards about every 3rd time. So there's a lot of different ways that can be done. So some commonalities with all of this is that we really use a team-based approach to doing all this work. So for example, as the attending physician, I'm writing prescriptions, I'm doing the notes. We have the addiction nurse, again, who's really the hub of all of this. She's talking to the patients for the first time. She's getting them set up for group. She's filling out forms with them. Whenever they have any questions or they're depressed or anxious, they call her. So she's really kind of the first point of contact for them. We have people scheduling people for group, the front desk. We have medical assistants helping collect urines. And then we have learners joining us as well. So I would say that there's no specific person you have to have on your team or not have on your team, but in general, some things that you should think about in doing this work is having somebody being the first point of contact, a triager, somebody who's going to initiate the buprenorphine prescriptions. After our OBOT nurse receives a call from a patient, she will get them set up with a doctor to start the Suboxone, and then after that they come to our groups and get all of the Suboxone in the group after that. And the other thing is, whenever anybody calls in, if they're appropriate, I usually just write a prescription without even seeing them and to get them to their appointment with me. Any day they're not on buprenorphine is a day they could to overdose and relapse. So we try to get them started on buprenorphine immediately. Then we have somebody who's going to keep their medication going, whether that's at an individual appointment or in a group setting. Oftentimes there's psych support associated with this. Now, a lot of physicians worry that if they don't have access to psych, then, oh my gosh, can I do this work? Of course you can do this work. It's great when you have access to therapists and psychiatrists, but you don't have to. Again, just starting people on buprenorphine alone can help them be much more stable in their life. It's nice to have a person who's available for questions, calls, medication issues. We have a medical assistant who works with us, and we have the OBOT nurse. So anytime people are having issues at the pharmacy, or they just have questions, there's usually somebody around who's able to answer their questions. And then the other component I think is really important is to have some kind of panel management, meaning what happens if somebody doesn't show or somebody's struggling. So what happens, what I do is I lead 2 back-to-back groups. I lead a group for an hour, that take a 15-minute break, lead another group for an hour. And then the whole team of us will meet, meaning me, the medical assistant, the nurse, we have a recovery coach, and we run the list. So we really have a panel. We run the list and think about, okay, who didn't come? How are we going to reach out to them? What are we going to do with their prescription? Who did come and that we're concerned about them? This person needs help getting to this appointment, or this person is struggling with housing issues. This person seemed really depressed. So let's reach out to them, and we farm out responsibilities. Okay, you're going to connect them to a therapist. You're going to give them a call midweek. You're going to connect them to our patient resource coordinator. So we think about managing them as a team, and that makes this feel very doable. Again, having medical assistant, front desk, and then having a higher level of care that you can refer patients to. I do recommend that if you develop a team of people who are doing this work, to have a backup for every position. But again, everybody who's been doing this work, really as a team, we look forward to it. This is like the highlight of our week, and taking a team approach can make this feel very doable when this is, usually a highly psychosocially complex patient population. We have regular meetings, we talk about patients, we divvy up work. It feels like a team sport. So briefly, what happens in our groups? What does this look like? So you can do urine drug screens. I actually am not a huge proponent of urine drug screens. We don't use these for putative purposes. We only usually check urines to help hold people accountable. And if something comes up in the urine that we weren't expecting, then we have a conversation with the patient. But mostly what group is, we welcome new people. We have new people coming in every week. We read the ground rules. These are, we developed ground rules that were developed by our patients. You can see here the things that our patient said were important to them. Be honest, be prompt, let us know if you're not coming. Respect everyone's experiences. They may be different from yours. Speak only for yourself. For example, say, I feel. One person speak at a time. Actively listen when others are speaking. Foul language is okay. Name calling is not. Silent cell phones. No texting. Don't glorify past drug use. Remember confidentiality in and outside a clinic. No attending group high. So we read our ground rules, then we do some kind of brief didactic, which I'll talk about in a second. And then, but most of our time is spent people going around checking, and they talk about their week, what's going on. It can be drug related. It doesn't need to be drug related. And we get to know each other, and we support each other. When somebody's going through something that's difficult, others chime in. And then at the end, they all get buprenorphine prescriptions. There's a lot of different things we can do to have the psychoeducation component, but this is really a minor part of the group. We could talk at them, talk about smoking cessation, talk about relapse prevention. Sometimes we can do a meditation exercise. Sometimes we just keep it simple and say, hey, talk about a moment of glory you had this week where something wonderful happened. So we keep that portion really short, and most of the time is spent doing check-ins where patients are supporting each other and talking about how their week is going. This is just a sample activity we did to give you a sense. We passed out a sheet on character flaws, and we asked them, circle 3 flaws you have that you don't like about yourself. For each one, list the reasons why you don't like this flaw. After check-in, share these with the group, and then crumble them up and throw them in the basket in the center of the table. We have had to modify some of our activities in the era of COVID to make them simpler. Okay, so some of the guiding principles. We have about 4 minutes, and then I'm going to stop and take questions. So some of the guiding principles behind all this work is that, 1, we recognize relapse as part of recovery. We are not going to kick people out if they're relapsing. We say, okay, you're struggling. How can we support you? We want people to be honest with us. And the more honest they are, that's how you engage in recovery. And we also recognize people may be using other things, like if they're using cocaine, the Suboxone isn't going to help their cocaine use disorder. So, what we do is we take a harm reduction approach, meaning keep you on your Suboxone. And then if you're still using other things, how can we help you how can we support you in other ways so that you are in recovery and are able to accomplish the things you want in your life? So some key features, I kind of mentioned a lot of this stuff, but, all of our groups have these very similar things, and there's some various other components. I'll let you read these on your own, but essentially, you can offer individual appointments. You don't have to offer individual appointments when you're doing a group type of thing. You can have different people involved. You don't have to have a therapist. You can have a therapist. Again, it's what your resources allow. We have a mix of patients in group, people who have been in recovery for a while, and then we have new people coming in all the time. Okay, so what do patients say about this model? Patients say that it holds them accountable, it keeps them honest, it's showing up every week, knowing that you have to be accountable for your actions. For me, I'm all about the consequences. There's another 80 times where I've almost slipped up and thought about this group, and I didn't do it because I didn't want to look at y'all in the face and say I did it again. Patients say that it helps them develop a shared identity. I will let you read this on your own time, but again, they're connecting with people who feel, who are like them. And they feel like they have a supportive community. It makes them feel like, yeah, this is a place where I can come, I feel safe, and everybody is similar to me. What does the clinic think of this model? So it is a great way to destigmatize addiction coming in the primary care setting. It's quite the lucrative model. And when I have a group of 10 to 15 people, then I see another group of 10 to 15 people. I can see 20 to 30 patients in a normal clinic setting. And then we're also able to bring them into primary care and get other primary care needs met. So it's a very productive model. One other model I'm going to briefly introduce is this idea of the hub and spoke system. So I talked about group therapy, I talked about individual therapy in a primary care setting. Another model is this idea of there's a hub where there's a bunch of addiction experts and kind of gurus who start patients on buprenorphine, get them stabilized, and then they send them to the spokes where people are maintaining them on their medications. I help mentor somebody who's doing this, who's trying to bring buprenorphine into the Duke system in North Carolina. And she's kind of doing a mini hub and spoke model where she's having her and 4 colleagues are going to start prescribing buprenorphine. They're going to kind of develop their expertise in it. And eventually their goal is to get other people to do the maintenance work later on. But that's how they're deciding to start this work is, yeah. So, okay, so I am not going to go through these frequently asked questions. I will let you know that they exist and you can read these on your own time because I want to save time for questions. But if you want to read through these later on, some of the questions that come up a lot is if people have to be on buprenorphine for life, can they take benzos on bupe? Do you worry about diverting buprenorphine? And is a lower dose better? No, it's not. And there's a lot of questions about how to start buprenorphine. And I have handouts that provide all of this information. So I am going to stop. I'll just wrap up with medication for opioid disorder has mortality benefit. We can prescribe Suboxone in the primary care setting and save lives and help patients live life in recovery while we address their other primary care needs. There are multiple ways to do this. You should consider your local resources, infrastructure, and support. Examples include group-based treatment, individual appointments, hub and spoke model. A team-based approach can feel fun, supportive, increase access to care, and is productive for the clinic. The alternative to this is patients using fentanyl on the street and could overdose and die. Even if you are new to doing this work, the benefits outweigh alternatives. We can do this. So I'm going to stop sharing my screen and open it up for questions.
Terrific, Randi. Thanks so much. We do have a couple questions, and they kind of fit into 3 themes. The first is some specifics about treatment. The second is about money, and the third is about training. Okay. So the first question is really about the specific. How much time do you have to wait for somebody to be opiate free before you can start them on buprenorphine?
Well, that is a long question. That could be a 5-hour answer. I will say that I did give you guys, it should say like opioid use disorder handout, and it has ways of starting Suboxone. So the short answer is, in the old days, we would usually wait 10 to 12 hours if they're on a short acting medication. You want them to be in opioid withdrawal. So if somebody was taking oxycodone, it usually takes 10 to 12 hours to get out of the system. They have to be scoring 8 on cows. And then there's algorithms. There should be something on your handout that says how to do it, but then you just start 4 milligrams of buprenorphine, you titrate it up over a day. However, in the era of fentanyl, now that fentanyl is in everything, fentanyl short acting, but sticks around in the body for a long, long time. So sometimes we have to do things a little bit different. There's new protocols called microdosing and macrodosing. Again, in the handout, it tells how to do that. So you might have to wait longer or overlap the Suboxone with the whatever they're taking. So there's different ways to do it. You can follow algorithms. There's a beautiful handout. I can send this to you guys too. If you Google Yale emergency medicine buprenorphine start, there is just like this beautiful, perfect handout that tells you how to do it. So I would check that out.
And one of our sessions coming on up will be specifically on how to initiate treatment. Second question about medicines. Do we need to worry about dual diagnosis in terms of mental health? And can we use other mental health medicines while we're also using Suboxone?
Totally. When I'm doing an intake with patients, I usually ask them about, what they've been diagnosed with before in the past, depression, anxiety, PTSD, and if they want to be started on medications, if they want to, great. You can do that at that visit. You can do it at future visits. Sometimes people just need to focus on their addiction now. There is some thought that sometimes, depression is related to addiction. If you treat the addiction, then they might not need antidepressants. But that's not the thing you need to worry about. If they're feeling depressed and they want to start on an SSRI, great. If they later feel like they don't need it, fine. But you don't have to start it. So it's more of a conversation of what the patient wants. Connecting them with therapists, connecting them with psychiatrists, if you have it, is great too.
Second goes to money. Are all these medicines generics?
So yes, you can get all these generically. And I am fortunate enough where I live in Massachusetts and we have Mass Health, so all this is covered. So it really depends on what your Medicaid programs cover, but everything is generic. The other thing, there's something called GoodRx. Have you guys heard of GoodRx? Mm-hmm. So that's another way you can literally get buprenorphine really, really cheap if you give patients that website and teach them how to use it.
Okay. Well, that answers the next question about Medicaid and whether they cover it or expanded Medicaid. You have a certain program there. We'll have to check into that for Arkansas. I do know I can't say that the commercially insured patients, all this we're doing this is because Blue Cross Blue Shield said we're spending too much money for folks coming into the emergency room. So we need to do something at the front end of things. Let's move on to practice issues and in the residency. Do you have any of your practitioners in your office prescribing Suboxone just integrated into their office setting?
So I will say that we did have everybody get waivered. So everybody, now you don't have to have the waiver, but everybody's been trained. At our clinic, though, we really use a model where, at least in our clinic, and this is not true of every place, but in our clinic, we have all our patients come to our group. And there's very little individual prescribing for opiate use disorder. Okay.
And, our folks are coming in from all around the state. Do you have any folks from your residency that are going out to rural practices and doing this in rural practices?
When they leave residency, yes. Where we live, it's not a rural area.
Okay. How do you approach a patient who, I don't have this problem?
So I will say that we are not selling this to people. This 100% of the time is usually people wanting help. People have to be ready for to be in recovery. You know, we can have discussions where we're concerned about them and we can express, I'm concerned, you know, that you have an opiate addiction, or, you know, that, you know, I mean, you can name it for patients, but they have to be ready for treatment. We are not going and saying, hey, do you want to be on Suboxone? These are people who are coming to us saying, I want to be on Suboxone. I need help. So it's not a program that you're selling to patients. Usually you say, we offer this, and they come to you.
And are some of your patients, were they primary care patients, family medicine patients prior to entering your system?
Oh, yes. Oh, yes.
Okay. I think we have time for one more question. And what I'd like to do is, we have about 10 or 15 questions here. We won't get to them all, but we'll tabulate these and maybe we can send them and you can write a few answers to them. There's no waiver anymore. So and I say this because we're going to go through the 8 hours. We had planned this program before the waiver while it was still in place. Are you going to continue in your program making sure that your residents have the 8 hours of training? And what's the benefit of that 8 hours of training, even if you don't get the waiver?
Yeah. So there's different ways to do this, you know, and I think this is going to evolve with time. I think we're going to have to figure that out. I think people need some training on buprenorphine, whether it is an 8-hour training or whether it's a few, you know, sessions, that whatever brings people to competency. So, you know, there's a lot of programs like PCSS and different things that offer these nicely packaged programs. So, you know, the more education we can give where people feel comfortable doing this, great. If there's shorter ways of doing it, great as well. So I think extra training is needed, whether an 8-hour course is needed, to be determined. But, you know, more training is not going to be harmful for sure.
Sure. And I just want to put in a plug. The PCCS training, I went through that. Leslie Stone went through that. Amber went through that. It's very boring. We're going to have case-based. It's going to be mini lectures. It's going to be a lot of fun. I think that's pretty much for our time. I do want to thank you so much, Randy, for participating. I also want to let you know that we have this very fancy UAMS coffee cup. We'll be sending that to you. The cup's in the mail, as they say, in appreciation for you joining us. It's been really a pleasure having you come virtually from Massachusetts to the natural state of Arkansas. And to know that I really think that you've started, you know, I hope the ball keeps rolling, not only this year, but next year and thereafter, because as you pointed out, it's a tremendous help for patients.
Thank you for having me. Reach out if you have any questions for sure.